Hey everyone, welcome to the Func Med Nation podcast. I'm your host, Dr. Steve Noseworthy. The views and opinions expressed by my guests in this podcast are not necessarily consistent with my own views and opinions. However, I do my best to be respectful of their views and opinions as they express them, even if they differ from my own. Now let's get to the podcast. Hey guys, welcome back to the Func Med Nation podcast. It's my pleasure today to be joined by a friend and a colleague, Dr. Peter Scire. We're going to be talking about some, no pun intended, some heady topics today. This is not going to be fluff, and it's not going to be superficial stuff. We're going to talk about the brain, the immune system, and some more recent research and some work that Peter has been doing in his practice and in conjunction with another colleague of ours. And before I just get onto a monologue, let me toss it over to you, Peter. And number one, thank you for making time to talk to me and to talk to anybody who's listening. And in most of the podcast interviews I've done, we've started with the origin story. So I know that you have a special story that led you into functional neurology, functional medicine. So why don't we just start with that? First of all, welcome to the show.
Thanks for inviting me here. I've been looking forward to catching up with you for a long time. So my introduction into chiropractic actually came at a very young age. I'm adopted. I was actually adopted from a Catholic ministry out of El Salvador, and so my parents, for several different reasons, couldn't have children, and so they adopted me, and early on in my childhood development realized that I had really bad asthma. And so I was actually one of those bubble kids that actually spent some time in one of those self-contained areas in the hospital and everything for really severe asthma. And my mom was doing some of the conventional stuff at the time, in the late 70s. But she actually got introduced to chiropractic by my grandmother, and my grandmother insisted that we go to a chiropractor and get adjusted. But also, he was doing some work back in the late 70s, where he was looking at muscle testing in relation to food allergies and everything. Right. He was very into the Feingold diet, and so we ended up doing all that. But then my mom also spent a lot of time uncovering that I probably had some type of learning disability. Now, early in my development, most of the primary care providers she took me to thought I had ADHD, that I had classic ADHD, and, suggested I go on Ritalin. So this is, fast forward to like 82, 83. Yeah. And, that was when kind of the Ritalin generation really began to start, right? And so, but she insisted that that's not what it was, that I had a really learning disability, that I struggled with reading, struggled with spelling and phonics and everything. So the combination of doing the dietary stuff and also working with some special educators that were really doing some cutting edge stuff at the time, over about a period of from first grade, being retained in first grade, to moving to fourth and fifth grade, I actually recovered and actually ended up going on to being a really good student by the time I hit junior high. Graduating in the top 10% of my high school class, and had the opportunity to, go to a really good, colleges. But while I was in high school, I was an athlete, and I had an injury, an ACL injury. But I also was getting chiropractic care throughout my athletic career. And so I got to shadow my orthopedic surgeon while I was in school. You could never do this today, where I actually would literally leave my high school and can walk across the street to the hospital, look at the board of who was operating surgeries, and just say, hey, can I sit in on the surgery? And because my surgeon was part of the staff there, I got to see a lot of orthopedic surgeries. But what's fascinating,
I didn't know that about your background.
Yeah. And so I did that. But what's really fascinating was that my orthopedic surgeon, his dad was a chiropractor. And so he had this utmost respect for chiropractors. And so on, that his dad was actually one of the board members of the New York State chiropractic board. And so he had a great relationship with my chiropractor. And so I got to see both parts of practice. I got to shadow my chiropractor in his practice, shadow the orthopedic. Yep. And the orthopedist was the one who really pushed me into chiropractic. He said that, listen, where managed care is going, that he was going to have to collapse his practice into a bigger practice and everything. And he said that he told me that he thought chiropractic had a better way of being able to practice, especially like if you wanted to do a cash practice. I mean, again, This is like 1995.
Yeah, this guy was way ahead of the curve.
Way ahead of his time.
Yeah.
And so he urged me to really explore chiropractic. And I always had such a positive chiropractic experience because I've been on the care all my life. So when I went off to college, I knew I was going to study biology, got into biology. And then I found, again, when I was in college in the mid 90s, that was the decade of the brain. So all this brain research was coming out. Okay. Yep. And I started reading a little bit more about the brain and talking to my chiropractor more. He said, understand that chiropractic's not really about orthopedics. It's mostly about neurology. And he was a Logan grad. And so he said that, why don't you go down to Life, check out Life University. He says some of the best, clinical technicians that he'd ever met came out of Life, and he wanted me to look at Logan and some other schools, but he felt like, I'd go down to Life, get a good education. And so I ended up moving to Atlanta, going to Life. And within my first year of being at Life, I had the pleasure of running into Dan Murphy. And anybody in our field who knows Dr. Dan Murphy from Life West, he's teaching every weekend. And so when I was beginning to struggle with some of the philosophy aspect of just being at Life, he grounded me in more of the science of chiropractic. And he was the one to then introduce me to how all of us probably got introduced to Ted Carrick. And so we got, introduced to chiropractic neurology, and then did that. And then that's how I ended up meeting Dr. Melillo back a couple years after that. And ended up really working in the childhood development arena.
Yeah. So my recollection, I think it was in the functional neurology circle that you and I first met many years ago. And just to kind of fill in some context for the rest of this conversation, like when I went through the neurology diplomate program and boarded, it was like 97. There was that was even before Carrick was talking about vestibulocerebellar integration. Everything was about the thalamus, right? Left thalamus, right thalamus, and that was almost like the sum total of the process. And the whole idea of the brain's interaction with an ability to monitor and control global human physiology, I don't think was really on functional neurology's radar somewhere around when Datis Karazian started teaching brain chemistry. And I think you and Rob were actually in the room when Datis taught that first seminar for Carrick.
Correct.
And I remember, because I had been in functional medicine then for several years, and I had been teaching the brain chemistry course, not in functional neurology circles, but just for other practitioners. And I remember having conversations with you and other people who were grounded in functional neurology, but really didn't have the functional medicine piece. And this was like groundbreaking stuff, right? And I remember for years, we would talk about, we have this sense that the brain interacts with the immune system, and that's really the topic for today. But we didn't really have very much knowledge or understanding of what that relationship was. And we would cite lesion studies where, you lesion the cerebellum and you lose your natural killer cell population, all that kind of stuff. But that it seemed to be stuck there for a while. And the conversation we're getting ready to have right now is light years beyond that initial, very fundamental, almost kindergartenish perception of how the brain and the immune system interact with each other. So I'm so eager to get into that conversation. I kind of want to jump right into it. But you mentioned before we started recording, you mentioned your collaboration with Dr. Melillo, Rob Melillo, and child development. And I'm going to make an assumption. You can correct me. Is it true that your own struggles when you were young with learning capacity, is that part of why a large part of your focus professionally has been on childhood development? Is that where that passion came from?
Yeah, I believe so. I mean, obviously, was so blown away with the model of functional neurology when I went through it and doing the diplomate program. And I did it obviously probably, I started in 2001. So I was,
Yeah.
8 or 9 years after you did it.
Yeah.
And because I think you did it around the same time Murphy was doing it, because I remember Murphy always talking about the thalamus and just this
Yeah.
cerebellum. So I had gone through a diplomate program from 2001 to 2004. And at the early part of 2004 is when I got to see Dr. Melillo lecture for the first time. And it coincided with his textbook being published. Okay. And this was really the first textbook that was ever published that we could probably hang our head on and say, hey, this is some defining research and academics of functional neurology. Okay. We'd go to seminars and we would cite research papers and everything and some text, some, anatomical books, but here was a book that was specifically written on, a functional neurological approach to what we did. And so that really just, when I read that book, I was like, okay, I gotta meet this guy. And it just so happened that he was going to be in Atlanta teaching like a couple months later. And matter of fact, we actually just celebrated our 20-year anniversary of me meeting him and saying, hey, I want to go up. I went up to him at lunch, probably like I went up to you at lunch and said, hey, let's go to lunch and chat or whatever. And I did that, and it forever changed my life, because within coming out of school and graduating in 2005, I'd already done some of his courses. So I immediately started working with kids right in my first practice. Even though I was still doing some traditional chiropractic, I would do that in the morning, and then in the afternoon, I'd actually work with children. And then that led me to then him coming to me and saying, hey, you built your practice up. You're seeing about 30, 40 kids, per month. Would you be interested in getting involved with this concept called brain balance? And, and so we started that together. And so we've continued that all these years, and then it's led to me teaching with him and everything. But yeah, definitely it goes back to me looking at my own struggles, and now, as a young adult at the time, realizing, okay, this is why I had those struggles and what was going on in my left hemisphere and causing my dyslexia and learning disability and some of the immunological challenges that I had, because I didn't. I mean, I had severe asthma. I had inflammatory states in my body that my parents had to pay attention to, how I was reacting to foods and what it would do to my brain. And so, yeah.
Okay. So, all right. So let's dive into the meat of the conversation. So the topic is, and there's going to be a lot of technical terms. So I'm going to do my best to put myself in the position of someone who knows nothing, so that if you use a term, I might stop you and say, okay, let's define that, or have you define that. But let's start with some kind of big picture terminology, like concepts of interoception, and eventually the subcategory of that, which is the immunoreception. But what is interoception? Just kind of capture that concept for us, and let's lay that down as the foundation for the rest of the discussion.
Yeah, I mean, interoception is how the brain actually senses the body states. Okay, and we can talk about it just on a rudimentary level. Let's say thirst and hunger and pain. But then also your states of feelings, okay? It's like, how do you, I tell people, like, how do you know you're having a headache, okay? Or someone made you upset and you have this certain body state that you have. So interoception on a simplicity level is just the sense of self, the sense of I, okay? And what we're finding out, there's a very specific area of the brain called the insular cortex. This is a very defined area that we realize now anatomically, that kind of sits behind some of our lobes of our brain, like our parietal and our temporal lobe. We were discovered, over 150 years ago, but it really wasn't until neuroimaging came about that we realized that there was a very defined anatomical representation of this, okay? And that there are very specific cells in this insular cortex called von Eckema cells, okay? And these are cells that basically sense the ability to have monkey see, monkey do. We refer to them as our mirror neurons. And we now know that there is clear distinction between the anterior part of the insular cortex and the posterior part of the insular cortex. The posterior part has a lot to do with your somatosensory input coming in. So again, whether it's pain perception or even touch perception, okay? And so any of that information coming in from your body, but then you also have your emotional state. And so that has to do with your anterior portion of your insular cortex. So how is your brain reading your overall viscera? How is it reading the information coming from your viscera that tells you about your body states? You wake up and you turn over one morning and you're like, I feel like a cold's coming on. Okay, well, how did you feel that? Okay, so what alerts the brain or lets the brain know is that insular cortex that perceives that information.
Right. So when we use and people hear the term cortex, like I think we have to recognize that, it doesn't matter if you're chiropractors like you and I, or if you're medical doctors, nurse practitioners, acupuncturists. When we graduate from our basic training that give us that credential, like none of us really understand the brain. Like, you have neuroanatomy. We did neurodissection in school. I didn't understand how the brain worked until I started learning functional neurology. So when you say cortex, I would imagine, unless somebody is already a neurologist, functional neurologist, I would imagine most people think, well, that's your frontal lobe, and that's my occipital lobe. So this thing called the insular cortex, you're telling me is essentially a different lobe of the brain?
Correct. Yeah.
That has a different function than, say, my frontal lobe, et cetera.
Exactly. And we even think, that you could say that about the anterior cingulate cortex now, okay? And maybe even in some functional terms, the limbic cortex, okay, that has to do with the amygdala.
Yeah.
So I think that over time, neuroimaging has allowed us to have more discriminatory aspects of these. And so, as you said, that, probably in our early education, it was just the 4 primary cortexes, right?
Yeah.
Like you said, the occipital lobe, the temporal lobe, the parietal lobe, and the frontal lobe. And then obviously, the differentiations of those lobes and like, for example, like with the frontal lobe, we have the orbital frontal cortex. We have the dorsolateral prefrontal cortex that has a lot to do with our executive functions, and we have our medial cortex that has to do with emotional regulation and everything. But now, we have these subcortex areas that we're beginning to understand have a really big role in our humanism. Okay. And especially when we look at it in terms of developmental neuroscience, which is really how I'm always going to approach it. And that's, I think, the impact that Dr. Melillo had on my life was, okay, when you're looking even in the adult population and you're looking at adult-based disorders, how is that related to a developmental neurological trajectory of the brain? Okay. And not to jump too far ahead of the conversation, but we know that the primary insular cortex is really in the right side of the brain. And that the right side of the brain has so much to do with our parasympathetic modulation. Okay. Again, the idea, can the right brain have as you were talking about earlier about lesion studies, we know going back even 30 years on some of these lesion studies, the different modulation of the right hemisphere and the left hemisphere in terms of the immune system. And so when we're talking about kids with developmental disorders like autism, one of the things that we've always known about autism in terms of the diagnosis is that they don't have a sense of self. They don't have this interoception, interoception. But then taking it one step further, they also have this tremendous inflammatory cascade systemically that's also impacting brain. And so I think that's where we've been going with this, is saying, okay, this merges very well, this whole new concept of immunoception into what Dr. Melillo has been hypothesizing for the last 30 years, is that the idea that there is this clear distinction between the hemispheres, and especially the right brain's ability to have more probably of an anti-inflammatory effect on the body.
Yeah. So there's a whole bunch in there that I would love to unpack. So the first is just kind of starting with an organizational framework that the lobes of the brain are more than the classic four lobes that we all learn in school, and that each of those lobes have different subcategories. But just take a moment, if you will, to address this idea of neurological networks, because when people in school learn about the frontal lobe, they learn like, here's the frontal lobe, here's where it is, and here's what it does. Here's the temporal lobe, here's where it is, here's what it does. And we learn them as these discrete brain regions when that serve different functions. But in reality, most, if not all of the functions that we and experience isn't the right word, but most of the functions that our brain serves is about distributed networks around different regions. So if that's true of the brain at large, is that also true of the insular cortex? Or does the insular cortex work in isolation?
No, I think you bring up the current way we look at neurology now is that we went from this lobular module, okay, of probably, from the time you learned neurology and I learned neurology, and the classic neurology being that, hey, these lobes, and then we have dysfunctional in these lobes. And then as the late 80s came about and the 90s came, and advanced imaging of the brain allowed us to now recognize that, no, the human brain has like these 8 or 9 major neural network hubs, and they're not equally distributed between the right and the left side of the brain. Okay. And there are clear distinctions from one side of the brain in that. So yes, the answer to your question about the insular cortex is also part of some of these subnetworks of the brain, okay, that we're beginning to maybe understand a little bit better, but there's still a lot of hypothesis about these. But at the end of the day, now we're talking about the idea of synchronization of these networks. Right. And then more specifically, how are these networks working in a interhemispheric relationship between the networks on the right side of the brain and the networks on the left side of the brain. Right. And so this is where we're at. This is where we're looking at this. Dr. Melillo has written tremendous new papers on this in the realms of childhood development disorders, but he also wrote a fantastic paper back last year on the brain asymmetry and how does actually brain asymmetry actually evolve. And he went through the evolution of it and showing how, even certain like birds have brain asymmetry. Okay, certain animals have brain asymmetry that's very distinctive. So this aspect of what are the networks doing on one side of the brain versus the other side, and really more specifically back to the idea of inflammation, that the right brain is going to have a lot more to do with an anti-inflammatory component, where the left brain is probably going to have more of an inflammatory relationship or turning on the immune system, okay, right, and saying go, but the right brain is what's going to really probably allow for that resolution to happen, and especially in inflammatory states.
Right, and in general, we consider healthy brain to have adequate action and control and synchronization between both hemispheres, or if we were to dive deeper hierarchically, within the different participating components of each of these different networks. Would that be an accurate way to say it?
Correct. Absolutely.
Yeah. So with respect to these networks that are distributed through different brain regions and might have aspects on both left and right side of the brain, you said earlier that the primary insular cortex is on the right side. Does that mean that there's only a right-sided insular cortex, or that there's a left and a right, but it just seems that the right is the primary locus of control of this sense of self, this sense of being able to perceive and understand what's happening inside my body?
Yes, there's both a left and a right, but just like we know that there is a vestibular relationship on both sides of the brain, but the primary localization is going to happen in the right side of the brain. And so when you bring into the relationship of the insular cortex, we also have to take into account for the parietal cortex, more the somatosensory component of the parietal cortex. Then we also look at the vestibular cortex. So there's actually a very particular area of what they call an association cortex, where there is the parietal, insular, vestibular, where all these informations come together and integrate and again, play a big role in this sense of self and body awareness. Okay.
So let me ask something that's, and maybe this is a better question for the end of the conversation, but I'm going to ask it now. It's just more in terms of practical applications, because in the world of functional neurology, one of many goals is to try to identify parts of the brain that are not activating the way that we want them to, either diminished or increased activation that might be inappropriate, and to design some kind of an intervention or therapy that would change that. So if we're seeing on the right-hand side, the parietal vestibular cortex and the insular cortex kind of working together in conjunction, if I'm hearing you correctly, could it be something as simple as, if I do something to activate my right parietal cortex, that's going to be of benefit to my insular cortex as well? Like if you stimulate one part of the system, does the whole system benefit?
Yeah, because I mean, one of the things that we're doing a lot with, and we just published a paper, Dr. Mo's lab published a paper, again, showing the use of TENS stimulation, just using some sensory feedback. Okay, you're not using it, in a muscle contraction level. You're just putting the TENS on, you're turning the TENS on. And what's really fascinating, that what we found with many children with autism, is that you could literally take the intensity to the full range of a TENS unit, and they may not feel it. Where you and I, we put the TENS pads on, we turn it up to 2, we feel it. But I've seen children where parents have literally turned it all the way up, and they're like, holy moly, they have no sense of perception of it, okay?
Yeah.
But now what's really cool is, as we start stimulating the right brain and we start doing the specific protocols that we're doing, all of a sudden now the child is telling us to bring it down, or they're actually crying for the first time when they fall down and actually cut their leg or something like that, or they I've had children over the years, you send them for blood chemistries and they don't flinch with the needle, okay, because again, this idea of this perception. So the answer to your question is what we refer to as stacking or co-activating, okay, but you could literally do a particular stimulation to this parietal cortex, whether it's adjustment, whether it's massage, whether it's just simple stretching the joint itself, okay?
Sensory brushing, something
sensory
like that.
Brushing, okay, or chiropractic adjustment, anything like that, to light up that area of the parietal cortex. Now, if you come in behind it and you do some type of activation to the vestibular system, you're going to obviously amplify that relationship. Yeah.
So let me just throw out a caveat, because you and I are going to have a tendency, especially with your background, to couch a lot of it in terms of kids with developmental issues. But all of this applies to adults too, doesn't it?
Absolutely. Because you look at you look at these brain asymmetries, and because I do work with adults, and a lot of times when you're looking at patients with chronic pain syndromes, okay, you start looking at we do a developmental history form, and you can actually start seeing some of the patterns and you start asking, like, hey, did you struggle in school? And they're like, yeah, I did. Or, I may have been a very high achiever, okay, and really academically gifted. And that might be that person that has a really savant-like left brain. But then you ask them about their social intelligence or their emotional intelligence, how they do in relationships, or do they tend to be someone who's a loner, and so you get into that, and then you can begin to say, well, wait a second, you got some of this history of some of these imbalances that are happening neurologically. We know, obviously, if you have an neurological imbalance, you are going to change the downstream functions of the immune system, the cardiovascular system. We look at that PIVC area as a major player in gastrointestinal function as well. Okay, so
define that for someone who doesn't know what the PIVC is.
Again, that parietal insular vestibular cortex, it has very specific regulation of the gastrointestinal tract, and so you see, because one of the things that we do see with a lot of the children with developmental disorders is they have quite a bit of leaky gut. okay, and if not the vast majority of them. And so you also look at, patients that have, right brain types of problems. Are they also prone to having more leaky gut issues as an adult? So I think that, for me, and I know for Dr. Melillo, one of the reasons why I wanted to come on here was I think that in the functional medicine space, we lose very much sight of functional neurology. Okay.
Absolutely.
Just like the functional neurology generation that you were a part of and the early part that I was also didn't have the functional medicine component of it. And then obviously Datis Karazian arrives on the scene and then we got to merge it. But I also still think that in the general education of the functional medicine community within the naturopathic community or the IFM community and some other communities, that they don't have a really good conceptual framework of how brain or the problem in brain asymmetry could be playing major downstream problems for these chronic fatigue, inflammatory kind of disorders that we're all seeing.
Yeah. And I think that one of the, having taught functional medicine in seminars for so many years, I get to talk to a lot of practitioners around the country. And you tend to go back to the same cities and interact with the same people. And I would say inevitably, the brain tends to be the most intimidating for clinicians, right? The immune system, not so much. Even the immune system, arguably, I don't know which is more complicated, right? The immune system or the brain. It might be a little bit of a toss-up. But it seems that the brain seems to be a lot more intimidating for clinicians than the immune system or other aspects, like, for example, endocrinology. Those systems are fairly easy to learn. Why do you think that is? And this is, a little bit off topic, but it's, I think, directly related to a deficit in our collective educational space, right? Why do you think the brain is so intimidating for people?
Yeah, I think both can be very intimidating. If, on the immune side, I think there's a lot of us that kind of take a very shallow level of it and don't go further in. And I know I've gone into the deep end of the pool over the last 6-7 years, and I still find it somewhat intimidating. But yeah, I do believe that because you can, and I think it goes back to the concept of some of the lesional work that we learned early on in our career, okay? That we learned to chase these very finite lesions based on symptom presentations and examination presentations.
Right.
And there's a lot of lesions, right? And we were taught that, we had 7 primary areas of the central nervous system that we were going through, and we would look at things going on in the spinal cord, and we might look at things going on in the peripheral nerve injury, okay? And then we would move up spinal cord, and then we'd move up to the brainstem. And so I think for us, it was intimidating, the concept that there was just so much material anatomically that we had to be responsible for, right? And then getting into, okay, what are all the primary disorders of the spinal cord or the primary disorders of the brainstem? And you get into the brainstem, and not only are we talking about very distinct parts of the brainstem, we're talking about the cranial nerves that live in the brainstem. And so now we had to learn cranial nerve, anatomy and everything. And that's even before we got to what we would all say is the brain, the cortex, right?
Yeah,
and then
exactly.
Be responsible for that. So I think that's where, because again, as a person who's been teaching in a postdoc program, I teach, I'm the co-instructor with Dr. Melillo in his 150-hour course. And I just see over the last 8 years of teaching, now almost 1,000 hours of courses, that, okay, that's a lot of intimidating information. And unless you're going home and reading the textbooks and going through your notes, because I know you guys with Apex have done a great job over the years when you do the brain chemistry class of doing maybe an hour or 90 minutes of, like, hey, let's just blow through some of this stuff. But, that's nothing. I mean, we took a 300-hour class program for our diplomate, right?
Right.
And so the same thing goes on the immune system is that, I think, over the years, Datis and you all have always done a good job of presenting some of the basics of the immune system. But I just have been actively involved with Sam Yannick's Cogent's immunology program now for 6 years. And I'm still not through the entire program because
Yeah.
the information is so evolving and so much.
Yeah.
So,
And
yeah.
it's like, it's the same thing, like with, functional neurology has changed so much since I went through the program, and the program I went through was different than what Carrick taught when he first started the program. What you went through is different.
Yep.
It's different now. It's
Yep.
constantly evolving. And, I had the pleasure of interviewing Sam when I launched the podcast last year or so. And I remember I told he was kind of embarrassed by this, but I dubbed him as the father of functional immunology, right? Because to my knowledge, he's the first person who's really kind of taken a much more advanced and nuanced collective understanding of immunology and put it into some kind of a course format. And we could go on and on and on about that. So let me just kind of help us refocus. We've talked about the insular cortex. We've talked about its primary function and localization. We've talked about its network characteristics and its primary role as essentially helping the brain understand internal states and the internal responses to external stimuli. Quite often I will, and I talk about this in different seminars, but back in, it was the late 90s, a researcher, Tomi Atada, coined the phrase the neuroendocrine immune supersystem. And it's always been my sense that when you look at brain hormones and immunology, and in essence, those are different facets of the same thing, it seems to me that the brain uses the immune system and the hormonal system to both understand and to control and coordinate peripheral body responses. Now, that's my perception. That's my understanding. Would you agree with that? And if you don't, how does your opinion differ?
No, I think as we continue to learn is that we know that there's when we're having an inflammatory effect going on, or we have a pathogen effect, obviously we're getting these signals that are being sent to the brain.
Yeah.
Now we're just understanding a better way how the brain is actually truly modulating all that, and through these very more defined circuits that are happening in the insular cortex. All the work that Kevin Tracy has done over the last 30 years from his lab in Long Island, looking at he was the one who defined the inflammatory reflex, or the anti-inflammatory reflex,
right,
and the role of vagus's perception, the afferent aspect of the vagus being sent all the inflammatory mediators from our cytokines or our toll-like receptors that are picking up these different senses of what's happening. Because again, I always tell people, on the basis of the immune system, think of it very simply. It's either looking at what's happening from a pathogenic load or what's happening from tissue injury. Okay, and either one of them are changing the state of what's happening in terms of these cytokines and chemokines and all these different immune senses. So that information is getting fed to the brain. And now we understand more discreetly that, hey, not only do we have this insular cortex area that's making decisions about what's going to happen at the peripheral immune response, but we also know the dorsal motor nucleus of vagus is having a response. We know an area called nucleus ambiguous is having a response to that. So I think the answer to your question is that we just now know better discreetly what areas of the brain are trying to modulate the brain from do I calm the immune response down, or do I need the immune system response to be more heightened?
Right.
And that's how I'm looking at it. So
right. So now we get to bridge terminology and go from the general function and concept of interoception, that brain's perception of self, to a subcomponent of that, which is the brain's perception of what's happening in the body as it relates to immunology and inflammation. And that's this term that was coined, I'm not sure exactly when it was, but I think within the last 10 years, correct me on that, called immunoception, which is the brain's perception of the immune system. And, I will admit that prior to you and I first starting to talk about having this topic, my understanding was, I would say, infantile, right? It was pretty basic. And I did some research on my own. You were kind enough to send me some recent papers, which I've read, which were, nothing short of mind blowing in terms of the concepts that they're revealing. And this is not, this is passed from, even though there's a lot left to clarify, it's passed from the realm of theory to, we know this is happening. Now we're just trying to sort out all the details. So let's define more specifically, if we can, what is immunoception as a subcategory of interoception, and can we roughly map out how this relationship between the brain and the immune system works?
Sure. So what my current understanding of immunoception is the idea that the brain can get all these signals from the peripheral and seems to now almost have like what they call an immunogram, where they now remember, this sense of what's happening in the body at that moment. So that way, when it happens again, the brain will know exactly how to orchestrate the immune system.
Yeah.
In a very discrete way. Okay. So it's just this leap in how the adaptive immune system is working, and even the innate immune system for that matter, because we have obviously these two very distinct parts of our immune system, and we know our innate immune system is like, hey, this very rapid response that has occurred over eons of time that we have, and then we have this very discrete adaptive response. But in either case, that the brain can, based on a prior experience, orchestrate this more exact immune response. Okay. Yeah. And now we're beginning to understand the connectivity of it back to the networks. Okay. That we know that, for instance, the insular cortex is talking to the hypothalamus. We know the insular cortex is talking to the brainstem and the midbrain. We know it's talking to the basal ganglia, specifically the striatum. Okay, we know the insular cortex is also talking to the frontal lobe and the temporal lobe. So this ability of saying, okay, it's not just, and so I think where we're going to end up is that we're probably going to have another network, and it's going to be this immune network, and we're going to know exactly in the next couple of years where we are. Kevin Tracy proposed over a decade ago the idea of an immunological homunculus. We're obviously in functional neurology and classic neurology, we're all know about the sensory homunculus that exists in our parietal lobe, and we know that on the posterior part of our frontal cortex we have our motor homunculus that we've, and that was work that was done by Brodmann in 1800s. Okay, but now the idea that in different parts of the brain that are controlling T and B lymphocytes or natural killer cell function or how your macrophages are working. I mean, that's where they're going with this work, and which is really fascinating.
Yeah, and just to add one piece to that in terms of these homuncular maps, right, these representations of the body and the brain, with the insular cortex, there is a viscerotopic map. Because I've posed the question, like when I've taught on the brain chemistry course that we teach, I'd ask people when we get to that section, like, how does your brain know where your liver is? Mm-hmm. How does it differentiate between your liver, your spleen, or the GI system, like small intestine? And there has to be a map in the brain of where all the organ systems are, and it just happens to be in the insular cortex.
Yep.
So this is mind-blowing. Like the idea that we can actually have an immunotopic map. And do you think, like from your reading of Tracy's work, is this immunotopic map, is this organized in the insular cortex as well? Or do you think it's some other place, or is it scattered?
It's scattered from what they're seeing. That they're seeing different regions of the brain and that's what I'm saying. I think we're going to maybe see a primary network, and then we're probably going to start beginning to look at sub-networks. And this is what leads back to all the work that Dr. Melillo is doing. I mean, that's where he really is right now. We're looking at these neural networks, and our hope is that with the groundbreaking work that he's been doing with his research partner, Jerry Leisman and Clesa Machada, and looking at neural networks in children, It just so happens that the main research in this idea of immunoception is in Israel at the University of Haifa, which also that's where Dr. Leisman is. And so we're hoping to catch up with both laboratories and begin to start exploring this, because, we feel like, can we start building a therapeutic model that's based on these neuroimmune activation sequences that,
right.
Can we, we've obviously seen in the world of immunology therapy, the idea of immunotherapy, especially if you get into the realm of what's happening in the cancer community, where they're getting more precise with how to modulate the immune response. I think this is the other thing that the functional medicine world needs to be better at. We can no longer just say, hey, let's just generalize stimulate the immune system. No, it don't work that way. Okay, we need to understand, back to Dr. Yannick's work about, Dr. Karazian was the first person to really introduce, I think, the concept, at least from my perspective, of T-cell polarization, him and Dr. Vajani. Dr. Yannick's taken it a whole nother level now to say, okay, based on the literature, we not only dealing with 4 primary T-cell positions, Th1, Th2, our regulatory system, and our Th17, but we got Th9 sitting out here. We got Th22 sitting out here. We got Th21. So we need to know when we decide to try to move the immune system with a supplement or a botanical, we need to know exactly how.
What are we doing? Yeah.
What are we doing?
So I have 2 things to say to that. First of all, for anyone listening who's heard of like the whole Th1, Th2 model of autoimmunity, like that's gone bye-bye. I mean, that's so rudimentary. Like it served us very well at the time when it was all new, and we're like so excited because, wow, now we understand the immune system. No, that was a little bit naive on our part. But we embraced it, and we did some good work with that. But there were many cases that I, applied the earliest version of the Th1, Th2 model, where, in some cases it changed someone's life, and in others it didn't do anything, and others it made them worse. And now I think with a more robust knowledge, which will continue to change, we have much better capacity to look at that and be more precise in clinical applications. The second thing I want to say is that I think one of the, like every industry, every profession has the good, the bad, and the ugly. I think one of the bad aspects of the functional medicine approach is that it has become very supplement centric, in the sense that, yes, people might, go to a course and learn how to do blood chemistry analysis or whatever the case is. But the intent is to, let me run labs to figure out what supplements to give someone. And that is, as a clinical model, not a bad thing. But when you start dealing with more complicated cases, that model is too simplistic, because there's much more detail that needs to be understood about that individual case. And so there's a big difference in the clinical management of someone who's relatively young, relatively healthy, with a recent onset GI problem that maybe you can attach to a recent event, versus that 55-year-old woman who's been chronically ill her whole life, who might have thyroid issues, autoimmunity, history of head injury, they're perimenopausal, and on top of that, they have a history of some form of abuse and all these neuroimmunological mechanisms that promote stress and inflammation are chronically active and very difficult to calm down. Those are diametrically opposed. And if you think you're just going to run a blood test and give an herb or some kind of a nutrient to that second case and be successful, you're in for a rude awakening.
Absolutely.
So I love this, because this conversation is highlighting, and I don't mind being shown where I don't know things like that. Like I may have said this to you before. I don't know everything, and it pisses me off because I want to desperately. Sure. And if that means that I talk to someone who's smarter than I am and shows me where I don't know something, and I can take something from there and build a better clinical approach, I'm all for that. So I think where we want this conversation to go ultimately is some clinical applications, and not necessarily specific applications, but at the very least, how do I order my thinking around certain complex cases to now start to account for hey, maybe the brain's part of this, but not stopping there, but going, gosh, the brain is intimately involved and perhaps completely inseparable from the immune system, right?
Yeah, I don't think, at least from my perspective, I don't know how you approach a chronic patient or even, like you said, that acute scenario without the merging of both functional medicine or, in to me, more the functional immunological side of things. Okay, because I think, if you're not looking at the functional immunology component of it, and and back to the T cell polarization concept for a moment, is that in 2009, Dr. Melillo wrote a landmark paper on functional disconnection syndrome.
Yeah.
And in that, he really delved into, and it was actually a paper that was 5 years after his textbook, where he delved into a lot of the brain asymmetry at the time and the immune system. Okay,
Yeah.
so then 2009, he rewrites a paper, and that was at the height of the early understanding of Th1 and Th2 and Th17. Where we're going with our work now and why we're so interested in trying to pull from these other researchers like Kevin Tracy and the women with the Immunoception is the idea now, can we expand on that? Can we begin to understand maybe the lateralization's role in the modulation of Th9 or Th22? Okay, so that's kind of where we're going from our laboratory standpoints in terms of research, and back to the clinical picture being, okay, that one, I think that you have to start out looking at that patient, and you brought up an example of ACEs, adverse childhood experiences. Okay, so how many people in the chronic fatigue world, probably if you gave them an ACEs test, are probably going to come back and probably have 8 to 10 ACEs. Okay, which are probably also superimposed on a brain asymmetry. Okay,
Yes.
well, for me, it always starts with, look for the brain asymmetry, look for the ACEs, and especially if you're dealing with somebody in their 20s and their 30s and their 40s, and then start working that route to say, okay, hey, I want to look at these functional asymmetries in brain because I know it's going to change the way the immune system is working, the way the gastrointestinal system is working. Because if all you're doing is trying to look at this, oh, this person's got leaky gut symptoms, or is got in these hormone symptoms, in these chronic cases, good luck trying to solve that.
Yeah.
Because it's such a linear model.
It is. And it's not to say that those approaches don't work in less complicated cases, because they clearly do.
They do, yeah.
Right? But, the challenge to anyone listening who, maybe you feel like you don't know as much about the brain or the immune system as perhaps you should, when you're faced with these challenging cases that don't respond to that typical approach, it's just simply because there's an aspect to the case that you're missing. And I think brain and immunology is critical. Let me bring us back to immunoreception, because I read those papers from Korn and Rolls that you sent me out of Israel. And I was trying to develop at least a simple framework of understanding what immunoreception is about. And you started talking about how the brain creates these engrams, basically these patterns of memory. In their papers, they refer to neuronal ensembles, which basically to me says it's an imprint of a pattern of activation that's a result of the inflammatory and immune response in the peripheral body, which is just blowing my mind. For example, I can injure my ankle, tear my ACL, and my brain has a picture of that. And I've done these things. I've injured my ankles. And so what that means then, and I understood this from a YouTube presentation that I can't remember who it was, Korn or Rolls, but she was talking about in some of the studies that they did, that once they identified the brain engram, like the neurons that were associated with a particular inflammatory event. And in this case, in their studies, they induced colitis in rodents and measured the brain activation. They could then turn around and, without having something in the intestinal system causing inflammation, stimulate those neurons on the brain, and the gut will get inflamed.
Yeah.
Right. And if that's not mind blowing to you, I don't know what is going to blow your mind. one step even beyond that is that my understanding of, in fact, she said this specifically, or they said this specifically in one of their papers, that the neurological side of this is necessary but not sufficient for this whole communication process to work, is that in order for the brain to control the immune system, not only do you have to have that engram imprint, not only do you have to have some kind of a neurological connection through the autonomic system down into peripheral tissue, but actually in the cells themselves, you have a memory imprint. In other words, the memory of the neuroimmune system happens in the brain and in the peripheral tissue itself. Like, this is like kaboom. Yeah. This is like science fiction stuff.
No, I mean, and I remember, because kind of just a historical aspect, Dr. Melillo had been talking about Kevin Tracy's work now for, at least 15 years. And when Tracy started publishing all this work, and that was a really mind blow at that time, because again, he was really looking at this inflammatory reflex and the relationship of vagus and how vagus is then going to send up this inflammatory relationship, and then we're going to get signaling down from our descending inhibitory signaling that's going to act on acetylcholine receptors that are going to then tell the macrophages to kind of calm itself down and everything. And that was a mind blow then. I mean, I remember, and then the whole idea of this immunological homunculus. And then about a year ago, he sends me this paper that Corin had written in like 2021. I think it was when they first wrote that paper. And we're like, whoa, okay, this takes us to a whole another level. It's almost like a matrix level here kind of thing, And so,
Yeah, I remember hearing many years ago, and I remember the conversation. I can't remember who it was with, but they pointed out some research where they were talking about just simple memories. I don't know that we understand exactly how memories are actually stored. And, even though we say, that the temporal lobe is important in that, it's obviously a network function as well. But I do remember someone saying that they had read some papers or been exposed to some research, or at least theories, that said that they believed that memories were encoded actually in the cellular tissue level in the peripheral body, in addition to up in the brain.
Yeah.
Which I kind of dismissed at the time, going like, I don't know how that would work, but, shame on me for having said that, because now clearly I need to go back to school.
Yeah. And that was, crazy part of my early education in chiropractic. I actually got to spend some time with Carl Pribham and Candy Pert when she was alive. And Candy Pert was the molecules of emotion person. Okay. Yeah. And she was the one female that got supposedly snubbed for the Nobel Prize, because she was actually the person that actually did the research as a graduate student. And Carl Pribham at Georgetown, but he's well known within the neurology circles of, a really big contributor to the engram. Okay. Yeah. And so again, and they were all, and this was like mid 90s as well, but even his work going way back into the 80s was talking, hypothesizing the idea that our memories are not just stored in our brain, okay, that they're stored within all, cells, living cells and stuff. So now this idea that we're talking about with the immunogram, the idea that yes, we're going to find these networks in the brain, but we also know there's stuff happening in the peripheral tissue and the single cells of the immune system.